Hello, dear colleagues. I'm happy to report the news from the ASCO GU annual meeting 2023 that took place from the 16th to 18th of February in San Francisco. It was certainly, again, a very interesting, very important Congress with the main news coming in the setting of metastatic prostate cancer. And so I would like to explain a few of the highlights from the prostate cancer session. And the main highlights were within the setting of metastatic castration-resistant disease, looking into the use of PARP inhibitors. And one of the most important studies presented was the Triton-3 trial. These results were also published in the New England Journal of Medicine the same day. Triton-3 is a randomized phase 3 study, including over 400 patients, looking at the use of the PARP inhibitor rucaparib in mCRPC patients who have been pre-treated with a prior novel hormonal agent. They could also have had chemotherapy, and they needed to have a BRCA mutation or an ATM mutation, and actually 75% of the patients had a BRCA mutation. The primary endpoint is radiographic progression-free survival, and so the use of rucaparib was associated with a clear benefit in rPFS in the BRCA mutated subgroup compared to the use of physician's choice treatment. And so clearly this reinforces that the use of a PARP inhibitor in mCRPC in BRCA mutated patients is associated with a benefit similar to what we have seen in the PROfound study using olaparib. For the Triton-3 trial, the overall survival is not yet mature. There is a trend, but I think this shows that the use of PARP inhibitor single agent in BRCA mutated patients is certainly warranted and important. So it's important to look out for BRCA mutations in your patients. The next two trials were also looking at the use of PARP inhibitors, but in combination with the novel hormonal agent. One study, the PROPEL study, has already been reported last year and published in the New England Journal of Medicine Evidence in 2022. PROPEL is a phase 3 study, including patients with mCRPC who have only been pre-treated with androgen deprivation. They might have had docetaxel in the hormone-sensitive setting. Around 20% of patients did have docetaxel. And then they were randomized to receive either abiraterone or the combination of abiraterone plus olaparib. And all comers were included in the study. That means not just patients with BRCA mutations or with homologous recombination repair deficiency, but also patients without such changes. And the number of BRCA mutations was 12%, and the number of HRR mutations was 27%. In total, 800 patients were included, and rPFS has already shown to be beneficial, especially in the patients with HRR mutations. And now the overall survival data were shown, and for the intention to treat analysis, the overall survival is just better with an upper limit of the hazard ratio of 1.0. But when looking a bit more into details, it's clear that patients with HRR mutations benefit much more as compared to patients without HRR mutations, where only a very minor difference is seen. So I think there are a few points that need to be discussed with the use of PARP inhibition in combination with a novel hormonal agent. But first, let's discuss the results of TALAPRO-2. TALAPRO-2 is very similar to PROPEL. So the same patient group, mCRPC patients only pre-treated with ADT and docetaxel, although 5% of the patients had received prior abiraterone, but that is a very small number. They were then randomized to receive enzalutamide or enzalutamide plus the PARP inhibitor talazoparib. Again, the primary endpoint is radiographic progression-free survival, and again, both HRR deficient and HRR non-deficient patients were included. Again, the number of patients with HRR deficiencies was similar to PROPEL, being 21%, BRCA2 was 6% of patients. And the rPFS for the whole group is improved, but looking again into the details, the radiographic progression-free survival for the HRR deficient is much better, with a hazard ratio of 0.46 as compared to 0.7 for the HRR non-deficient. So what we have is two studies looking into a setting where these days we do not have so many patients anymore, because both PROPEL and TALAPRO-2 included patients who had ADT only in the hormone-sensitive setting and were then receiving the novel hormonal agents in the castration-resistant setting. Whereas these days, as you know, we mainly use novel hormonal agents earlier on in the hormone-sensitive setting. So this makes it very difficult to interpret the results of these trials. But both show that certainly the combination is improving outcomes in patients with BRCA mutations, in patients with homologous recombination repair mutations or deficiency, whereas it is less clear, but there is a trend for improvement also in the non-HRR mutated patients. So for the clinical impact, it's difficult to know. Certainly test for BRCA mutations. Also, I would suggest test for HRR mutations, but for the time being, single agent PARP inhibitor remains standard of care, whereas the combination is reserved to the patients who had only ADT single agent in the sensitive setting. So finally, I would like to discuss the results of the ARASENS study. ARASENS was in the setting of metastatic hormone-sensitive prostate cancer, looking at the combination of ADT plus docetaxel, or the triple of ADT plus docetaxel and the novel anti-androgen darolutamide. The first overall survival results were presented and published in the New England Journal of Medicine last year, showing a benefit for the triple combination. Now they looked at the subgroup analysis of the high volume versus low volume, high risk versus low risk patients. And essentially, the majority of patients included has high volume disease, 77%. 70% had high risk disease according to the known definitions. And there is a clear benefit, especially for the high volume patients, whereas the low volume patients appear to derive very little benefit from the triple. Interestingly, when looking at risk groups, both the high and the low risk groups have a very similar benefit of the triple combination. So for me, I think certainly high volume patients are good candidates for a triple treatment with ADT, docetaxel, darolutamide, if they're fit for docetaxel, whereas in the low volume patients, I think a combination of ADT plus a novel hormonal agent is sufficient. So that was it for the prostate cancer setting, and thank you very much for your attention.